Welcome to Case Management, brought to you by allceus.com. Case management isn't something that we typically talk about as separate from what counselors do or probation officers do, but case management itself is a profession. Generally, a case manager performs functions such as assessment, treatment planning, linkage, monitoring, and advocacy. We'll look at each of those more closely in future slides. Case managers help enhance the scope of addictions treatment and the recovery continuum. Case managers will often provide the client with a single point of contact for multiple systems. So if you've got a client that's, say, seeing a psychiatrist, seeing a mental health counselor, and seeing a substance abuse counselor, the case manager will work to be the single point of contact to improve communication between those three people. If you start adding in a vocational rehabilitation counselor, a Department of Children and Families case manager, and a probation officer, you can see where a case manager can greatly help increase the functioning of a multidisciplinary system. Case managers also advocate for the client. They're the ones that typically see the client most often and can help communicate to other team members what's going on with the client and what the client may need. For example, they see the client more often, so they may be more able to notice changes in the client's behavior that may indicate medication needs to be adjusted or treatment plans need to be adjusted. Case management needs to be flexible, community-based, and client-oriented. We got the client-oriented part. The individual client has individual needs that we need to address. We can't just say that all substance abuse clients need these services. It's never going to work. So we need to address the client as an individual and address their needs individually. It needs to be community-based. A client doesn't live in a vacuum. If we help them learn how to use the resources within the community while they're in treatment or while they're working with a case manager, they're going to be more able to use those same resources when they're discharged from treatment. Further, it reduces the burden on any one agency if all of the services that are already out there are utilized to maximum effectiveness. And finally, it has to be flexible. Clients change. Situations change. If we are rigid in our approach to treatment, we're not going to be very successful. Likewise, a case manager may have to drop back and punt sometimes. Initially, you may anticipate a client doing X, Y, and Z on a given day or making certain linkages, but you may show up at their house to pick them up to take them to wherever they're going and find out that they've decompensated and they need to go to see a psychiatrist or they need to go into detox. It needs to be flexible. Then the case manager needs to work with the team to evaluate what was happening in that person's situation that needs to be tweaked a little bit in order to increase the chances that they will succeed in the future. Case managers also assist the client with needs generally thought to be outside the realm of substance abuse treatment, linking with child care services, linking with food stamps, linking with medical doctors, dentists, things that we all know have to be addressed in order for someone to be successful in substance abuse or mental health treatment, but unfortunately they're not compensable things. They don't count as billable hours for clinicians. Therefore, many clinicians are discouraged from engaging in these things. Case managers have to have certain knowledge, skills, and attitudes. First, it's important that you understand the various models and theories of addiction and related issues. And that and related issues is sort of like and other duties as assigned on a job description. It encompasses a lot. Domestic violence, child abuse, PTSD, how the other systems impact treatment, addiction, all the mental health issues that frequently co-occur with substance abuse. There's a lot a case manager needs to know. Yes, it's true you're not going to be the one providing substance abuse treatment or mental health treatment, but you do need to be aware of the signs and symptoms of addiction, of drug intoxication, of drug withdrawal, and of all the major mental health diagnoses. That way you can identify when a person has unmet needs or when they may begin decompensating. It's important that you can describe the best practices for treatment, recovery, relapse prevention, and continuing care. Again, this is individualized, and as we're seeing now, the community is moving more towards best practices for treatment with co-occurring disorders. We recognize that most substance abuse has a mental health component to it, but that will differ. You're going to have a myriad of possibilities. Somebody with depression and cocaine abuse, somebody with anxiety and stimulant abuse, somebody with schizophrenia and cocaine abuse. There's any number of possibilities you may have, which leads you back to that individualized case planning. It's also important to recognize the importance of family, social networks, community systems, and self-help groups. Many people who've been abusing substances either don't have a strong social support network or they are enmeshed in a substance abusing social support network. That's not going to support them in recovery. So it's important for us to understand how the family impacts the development of addiction, how sober social supports impact the recovery process, and how to help people link with positive, sober social supports. The next thing to be aware of is the variety of insurance and health maintenance options available and how to access them. Many times if you work in an agency, there will be a certain subset that you have to be aware of, what you can bill for, what you can't bill for. But there are also other things out there, such as prescription drug plans, that you need to be aware of. Can client A print out a voucher from the pharmaceutical company that makes her medication and get her meds for free if the doctor signs the voucher? Can the client go to Walmart, for example, and take advantage of their prescription drug plans, or Publix? What special prescription drug plans are available at your local pharmacies? All of these things are important because medication noncompliance is very often spurred by medication lack of affordability. Helping clients afford their medication makes it more possible for them to be treatment compliant. The next step is to work with them and advocate for them with their physician and with their counselor if their medications are not working as they should, or if the side effects are keeping them from being treatment compliant. Help them advocate for themselves and say, you know, I really can't take this medication because it makes me feel sleepy all day long, or it has whatever other side effects, and I probably am not going to be treatment compliant in the long term. It's much better for them to be forthright with their physician than to start monkeying with their own medications. Next, it's important to understand the diverse cultures and relevant needs of culturally diverse groups. You can't just lump people together by their diagnosis. You can't just lump people together by their culture. But it is important to be aware of cultural mores and be sensitive. If a client doesn't necessarily fit into the model that you would expect, if you look at his or her cultural upbringing, it may give you an idea about why they're not making eye contact, or why they seem to be guarded in what they tell you, or a variety of other things. Violating these boundaries is not going to help treatment any. you need to be able to work within what is culturally sanctioned and what is culturally comfortable for your client. And you need to understand the value of an interdisciplinary approach. I'm not a physician. I have suggestions based on my clinical experience and what has been reported to me by my clients about what medications tend to be more or less helpful in certain situations. But by no means am I the one to make the decision. I am able to give input. I'm able to help the client understand about side effects. But the physician is ultimately responsible for the medical aspect. Likewise, everybody has their own specialty. If you have someone who is specifically an addictions treatment provider, they will need to communicate with the mental health treatment provider. A person is complex. They need people to address mental health issues, physical issues, social issues, employment issues, housing issues. All of their needs need to be met in order for them to be successful. Treatment versus case management. Substance abuse treatment and case management functions differ. It's not just two people doing the same thing going by different titles. Treatment involves activities that help addicts recognize their problems, acquire the motivation and tools to stay clean and sober, and use those tools in day-to-day practice. Case management supports a client as he or she moves through the recovery continuum and reinforces treatment goals. The counselor is very rarely going to go out and do a home visit or interact with the client outside of group therapy or individual therapy. The case manager, however, does. So the case manager helps the client internalize and operationalize the skills and tools he learns in treatment. Case managers can help clients actually walk through the steps of problem solving, walk through the steps of identifying and linking with resources to empower them so they know how to do it when they get out of treatment. The goal of interagency case management is to expand the network of services available to clients. Vocational rehabilitation, Department of Children and Families, Social Services, food stamps, whatever it's called in your area. Probation and parole sometimes. Addictions treatment, mental health treatment, medical treatment, dental treatment. All of these things are often provided by separate entities. And in order to make it work, we have to have that single point of contact, which is the case manager, to help all the different people communicate in an effective, timely fashion. 3 interagency models have been identified. The single agency model, in which the case manager personally establishes a series of relationships on an as-needed basis. So they work for company X, and as each client comes through their office, they establish relationships throughout the community. Informal partnerships, on the other hand, staff members from several agencies work as a collaborative team. They may meet once a week. Once a week is probably too much. Once a month, once a quarter, to discuss clients that they may have and needs which are occurring and refer among themselves. So there's a core group of people that meets and facilitates referrals on a regular basis. And a formal consortium binds case managers and service providers through written formal agreements. So if your agency has written agreements, say, with the hospital and with probation and parole and with vocational rehabilitation that identifies how you will work together and what services will be provided by each agency. That's the formal consortium. That's rare. Normally, you're going to encounter a single agency model. Sometimes, if you're really lucky, you'll have an informal partnership. Formalized connections among agencies include memoranda of understanding and interagency agreements and contracts. So you can ask your boss or whomever, do we have a memoranda of understanding with this company or this agency? Or do we have an interagency agreement? And if so, can I see it? You need to know if there is a formalized agreement, what your agency has already said that they're going to be responsible for doing, because you, therefore, are responsible for upholding your agency's end of the bargain. The environmental assessment. An analysis of the community environment will enhance understanding of the changes that occur among clients within the program and in the community. So depending on where your client lives, whether it be in residential treatment, in jail, in a community, out in the community, so to speak, their environment is going to differ. Nevertheless, the environment will change your clients, and your clients will change the environment. There's a reciprocal interaction that's going to occur there, and it's important to understand what's going to occur and anticipate what's going to occur. For example, if you have a client in early recovery who's living in a community where, as one of my clients put it, people go around and sell drugs like the Avon lady, you know that that person's not going to be safe as far as staying clean and sober. That's one of the first steps or things that needs to be communicated in the treatment to the treatment team as a priority for trying to fix in order to keep this person clean and sober. Case management indicators of success must be defined by the substance abuse program and its stakeholders. What does that mean? Well, that means we all define success differently, and unfortunately, a lot of times it's defined by whatever we need to define it by in order to get our funding every year. You should have for yourself, though, a list of parameters which indicate successful completion for your clients. What does it mean to you to have a client successfully complete? You have to remember that successful completion for some people is going to look very different than for others because they're going to start at a different level. And they may be able to, certain people are not going to be able to achieve the same gains as others. That's just the way it is. So consider how you define success. Maximal improvement for that person? Okay, well, that's still pretty ambiguous. So in terms of any particular client, set in your mind, what would I hope the outcome would be for Jim Bob? What would I hope the outcome would be for Sally Sue? Likewise, a successful completion, your client needs to have some say in it. You are not dictating his or her life. So ask them, what would it mean to successfully complete treatment to you? What would that look like? What would be different? Would you have a job? Would you not have a job? Would you have a part-time job? Would you be volunteering? What would your relationships be like? Things that we typically use in motivational interviewing and brief interventions can be employed in case management. If your idea of successful completion differs greatly from the client's idea of successful completion, you're going to be sorely disappointed because the client is going to go in the direction that he or she wants to go. Therefore, again, get their input on what their hopes for treatment outcome will look like. In documenting a case management effort, it's necessary to establish benchmarks to measure the case management process. Timelines. You want to establish that these 5 things will occur by this given date. Again, you're going to work with your client to establish long-term and short-term goals, because your client's not going to be motivated to do your goals because they're not important to him or her. So identify where your client wants to be ultimately, and then you can work backwards in order to identify the small steps that they need to go through to get there. Benchmarks are system outcomes which measure cost savings and quality of care, and they're determined from the treatment objectives. Cost savings. Now that sounds horrible to say, but if you take 8 case managers and put their caseloads side by side, and one case manager's clients typically stay in treatment 2 or 3 times longer than everybody else's, that's not a good cost savings. You would have to really do an analysis of that person's caseload to see if their people were that much worse off or whether their benchmarks need to be adjusted. They need to do some things to facilitate effective, efficient treatment. In order to work and create effective, efficient treatment, there need to be structured feedback loops for quality assurance. It ensures that the gathered data are returned to various stakeholders and that the data is meaningful, which means it has to be adequately defined. Again, this whole idea of successful completion is pretty fuzzy, especially when it comes to filling out paperwork, unfortunately. So exactly what does it mean for successful completion? Exactly what are your benchmarks? And these need to be objective, not subjective ideas of the client is doing remarkably better. Time in treatment, cost per person, resource utilization, compared to that person's diagnosis. Someone with hepatitis C, schizophrenia, and a history of polysubstance abuse is clearly going to use more resources than someone who has a short-term history of alcohol abuse and no co-occurring diagnoses. So you need to make sure to compare apples with apples, but you also need to make sure that efficient best practices are being used. When you notice there's a lag in the system, by getting the data back and evaluating it, maybe people are staying in treatment way too long, or they're staying in aftercare way too long, then that data will impact the shaping of future program development. How can we more efficiently move people through the system without reducing quality? For example, instead of doing 6 months of individual treatment, do 8 to 10 weeks of individual treatment, reassess the patient, and if they're stable enough, step them down to twice a month individual treatment and twice a month group treatment. Then they can be stepped down further to once a month individual and 3 times a month group. Same thing can be held true for case management. Start out if the person needs daily visits from the case manager, but set benchmarks for the goals for stepping a person down for visits, down to once a week maybe. The nice thing about case management is it can be adapted to meet the sometimes contradictory needs of various stakeholders. As the example I gave before, you need to provide high-quality intensive treatment to people, yet we need to do it cost-effectively. So by utilizing other agencies to provide, say, vocational rehabilitation services and medical services, psychiatric services, you're reducing the financial burden on your agency, but also making sure that the person maintains high-quality treatment. By incorporating group treatment and community-based support groups, you're still maintaining frequent contact with that person, but it's not the individualized contact, which is more expensive. A management information system provides stakeholders access to all of the case management services information. This is your database. Basically, it tracks data on programs, on clients, and on case managers and clinicians. You can run reports to figure out who's being effective, who's using what, who's doing their paperwork, who's having a lot of paybacks because their paperwork is incomplete. Regardless, the management information system tends to be the nemesis of most frontline workers because it's the stuff that we hate to do. Even as a supervisor, I hated doing the paperwork. I liked working with the clients. I liked working with the programs and working with the people. But it was a necessary evil for funding. So work with your senior management in order to identify replications in the system, ways you can save time and still gather the data that you need, as well as things that need to be included in the management information system that are not already there. For example, a listing of each agency with which you have an agreement, formal or informal, a contact person, and a phone number that's accessible on your intranet. That would be useful to have. They can also track how often you're contacting those different agencies, which provides all your number crunchers, the stuff that they're happy with. And I'm a number cruncher. I love charts and graphs, so don't get me wrong. But you have to sell it to them. Why do we need to add this piece of data or add this piece of information to our data system? And how will it improve your efficiency? All staff members of a specific program should be stakeholders in the management information system, which increases accuracy and the likelihood that a broad array of staff will use it. If you make it too hard, if you make it too complicated, people will shy away from it. What you can do is have the minimum amount of information that is needed to automate effective case tracking and communication between people. It's the other beauty of a management information system is that it has the information in one place. So the clinician can log in and see when the last time the case manager saw Jim Bob, and what the case notes are. And the case manager can log in likewise and see what the clinician is doing with Jim Bob without having to actually make phone contact or face-to-face contact with the clinician. Saves everybody time. It also increases the effectiveness and reduces errors if it's all right there in black and white. When we talk about case management or counseling or anything else, we understand that it's a developing field. Everything develops. Engineering develops, astronomy develops, counseling develops. So what do we need to look at in the future? For one, how do we reach these hard-to-reach populations? People who are homebound, rural populations, people with significant impairments in their ability to communicate, people with significant cognitive impairments. What's the cost effectiveness of particular case management models? How can we effectively investigate things in real-world settings? We need to develop brief versions of outcome instrumentation. So if you're administering a test-retest to assess for quality of life or depression or suicidal ideation, we need to have brief versions that can be used in the field that are reliable and valid. We need to look at the effect of particular forms of case management on the societal costs of substance abuse and its treatment. So we typically look at how case management affects the individual in treatment. But we need to make our scope broader. If that person receives case management services and starts improving, what are the societal benefits, I guess, that we can look at? What sort of reduction in cost do we have? Reduction in court costs, reduction in costs for incarceration, reduction in restitution, reduction in medical costs from their victims. Lots of cost savings go into effective treatment with offenders. Finally, we need to look at creative ways to use secondary data sets to determine trends and patterns of care. Our primary data set is the client. They came in, did they successfully complete? But secondary data sets can look at what sorts of treatment are used. When clients are exposed to X treatment, what are the effects? What are the patterns of care? When this is taken out or when this is added in order to help develop best practices that are appropriate for different cultural groups and different areas and regions within the U.S. For example, rural Nebraska will have very different treatment protocols than right smack dab in the middle of New York, New York. Case managers need to have special attitudes for dealing with special needs clients. For the first thing, you need to know what the special circumstances are that affect your special needs clients, and understand the range of clients' reactions to the challenges associated with particular circumstances, whether that's physical disability, mental disability, substance abuse, having their children taken away. There are a lot of special issues that face people in substance abuse recovery. Case managers need to be aware of these and how they're going to impact a client's treatment. Within that awareness, you need to be aware of the limitations of your own knowledge and expertise. Know when to refer. There might be times when it's appropriate just to hear Sally Sue out, and other times when Sally Sue really needs to be referred for an emergency appointment with her counselor. You need to maintain an open attitude about seeking and accepting assistance on behalf of a client. Don't get all high and mighty. None of us have all the answers. So we need to be able to reach out even to other case managers and say, you know, I don't know what the best thing is to do for Sally at this point. That's the beauty of an interdisciplinary team and a company or an organization that works well. You always have people to consult with. And if assistance is offered, be open to the suggestions. Finally, know where additional information on special problems can be accessed. So if you're working with Sally Sue, and Sally Sue's family wants to know more about addiction, be knowledgeable about where the informational resources are. Case management has certain principles. It offers the client a single point of contact with the health and social service systems. It's client-driven and driven by client need. That's not by billable hours. It's driven by client need. It involves advocacy. It's community-based, pragmatic, or practical, anticipatory, flexible, and culturally sensitive. The best case manager can anticipate problems that might arise based on knowledge of their person's particular situation and how that will interact within the community and what might be needed in order to help this person attain recovery, sobriety, whatever. There are 5 elements associated with becoming culturally competent. First, we have to value diversity. That means it's not my way or the highway. We have to value people's ability and desire to choose things that may be different from what we would. We need to make a cultural self-assessment to know our own values. We need to understand the dynamics of cultural interaction. As a white, heterosexual female, how does that impact how I may interact with some of my clients? Incorporating cultural knowledge. If you know, and you should, at least minimally, about what typical cultural practices are with regard to verbal and nonverbal communication and social mores, then you can integrate that into the way that you approach your clients. Then adapt practices to the diversity present in a given setting. If you're working in a group setting and you've got a very diverse group, you're going to need to be more sensitive in the treatment approaches that you implement. Likewise, if you are working in a situation that is relatively homogeneous, you can utilize different treatment approaches which may be more effective with that particular group. Anytime you're doing case management, you're going to end up making referrals. The important elements of referrals include establishing and maintaining relations with civic groups, agencies, other professionals, governmental entities, and the community at large to ensure that you have appropriate resources. You need to identify service gaps and work to expand community resources to help address unmet needs. So what does that all mean? That means you need to go out and network. You need to make sure that you have resources for housing, medical care, dental care, and more than one resource. Psychiatric care, transportation, phone service. Have connections with the agencies with which you regularly interact, the Department of Children and Families, the court system, social services, the health department. Identify any unmet needs that are out there. For example, homeless shelters, shelters for pregnant teens, runaway shelters. When you identify these, you're not going to be able to create them overnight. But if you bring them to the forefront of the attention of the people who can change things, then you're doing your part. You need to continuously assess and evaluate referral resources to determine their appropriateness. If you're referring to an agency and things are going well and clients are being received and whatever needs to be done is taking place, great. But if you start referring to an agency and their responsiveness starts to decline, the first thing to do is advocate for the patient. Try to find out why they're not being responsive. But if that agency stops meeting your needs, you need to find another agency. Differentiate between situations in which it's more appropriate for the client to self-refer to a resource and those in which a counselor referral is required. And typically, unless a counselor referral is required for compensation, for example, if you're referring to a psychiatrist within your agency, it may have to come from a counselor. But unless it's required that the counselor refers, it's typically better for the client to be empowered to make the referral for him or herself. It will be more meaningful in the long run. Not only are they going to be more likely to follow through if they themselves made the appointment, but they will also have learned the skill of how to make a referral for themselves and how to advocate for themselves. When you arrange referrals to other professionals or other appropriate resources, you want to make sure that they meet the client's needs. It's not just, well, I always refer to everybody to go see vocational rehab, and I always refer everybody to go to food stamps, and I always refer everybody to go here. Make sure you're not making superfluous referrals. Number one, it'll burn out your referral resources, and they're not going to want to see your people anymore. Number two, it'll burn out your clients, and they're not going to want to do everything because they feel like they're running hither, there, and everywhere. So make sure that you arrange the referrals, you effectively communicate to them everything that you legally can without breaching confidentiality, so that they can best treat the patient with a minimum amount of redundancy. It's a real pain for clients when they have to go to 4 different places and do 4 different assessments and fill out 4 demographic forms, etc. If you can reduce some of the duplication of effort, you're going to save everybody a lot of time. Explain in clear and specific language the necessity for and the process of referral to increase the likelihood of a client understanding and following through. So if there's a need for a referral, most likely the client's going to get it. But if they don't, be very explicit as to why you're making the referral for them and the steps that they need to take, including where they need to go, the phone number, ideally directions for how to get there, what time they need to be there, and any other information which they may need in order to facilitate the referral. Then exchange relevant information with the agency or professional to whom the referral is being made in a manner consistent with confidentiality regulations. You're most likely going to need to get a release of information from your client. But you're going to need to do that before you make the appointment for them anyway. Make sure that the client spells out very specifically what you're allowed to say and what issues you're allowed to address with that particular referral resource. HIPAA has made it much more precise as far as revealing information to referral resources. So it's important to document what you're doing. And then evaluate the outcome of the referral. When you meet with Sally at the next time after she sees the referral, ask her how it went. Did she feel comfortable? Was it helpful? And if not, then you can start troubleshooting from there to see whether Sally needs something else or whether the referral resource is not working in the way that you intended it to. Once you make the referral and you start involving other people in the treatment team, you need to coordinate services. In order to implement the treatment plan, which, being the single point of contact, you're probably going to be the one in charge of the treatment plan, or at least holding the treatment plan, you need to initiate collaboration with the referral source. Call them up. If they don't send you their treatment plan, call them up and say, okay, what needs to be included in Sally Sue's treatment plan in order to make sure she gets treatment services from you. Obtain, review, and interpret all relevant screening, assessment, and initial treatment planning information. Some agencies don't have case managers do this, some do. It's important to be able to understand, even if you're not treating people, it's important to be able to understand all of the information that's being gleaned during the initial assessment so you know what to expect and you can best advocate for your client. Confirm the client's eligibility for admission and continued readiness for treatment and change. Eligibility is often determined by the fiscal department or someone else, but if it's your responsibility to get the pre-approval, then make that happen. You are the one that is seeing that person most often as the case manager. So if their readiness for change, if their motivation is waning, it's important to let the treatment team know, as well as to communicate with the client and find out what's going on. Then you want to complete the necessary administrative procedures for admission to treatment, because nobody can see them unless they're admitted and they can be billed for. And coordinate all treatment activities with services provided to the client by other resources. So it's your job basically to schedule them. You don't want to have overlapping appointments. And sometimes, especially in early recovery, clients have difficulty managing their schedule and not double booking themselves and figuring out that they can't get from one side of the town to the other in 15 minutes. So it's important to work with them as they set up their schedule, especially when they're self-referring for a lot of things, to review their schedule with them to make sure that it's realistic to get to their appointments on time. Then establish realistic treatment and recovery expectations with the client and involved others, including the nature of services. What exactly can we do for you? What are the program's goals and procedures? Every program has goals. We would be lying if we said it's whatever the client needs. Now, we all have goals. We need you to successfully complete treatment and remain clean and sober for 30 days. Whatever your treatment goals are. Program procedures. What's going to happen while the person's in treatment? If they're an outpatient, how often will they be expected to show up? When will they be expected to pay? What's their copay? Anything they may need to know. Basically, this is their orientation. Rules regarding client conduct. Schedule of treatment activities. Costs of treatment. Factors affecting duration of care. What might get your care cut short? Non-compliance, referral to another program because you become suicidal or because you are actively using substances, whatever. Likewise, you're going to have involuntary clients that want to know how fast they can get out of there and what they can do to expedite their discharge. And clients' rights and responsibilities. What are their rights? One of the things that I tell my clients, or when I was in community mental health, this whole case file was very mysterious to them. And progress notes were very ominous to a lot of my clients because they either had a case plan with the Department of Children and Families or a probation officer or something. I never put anything in my progress notes that I wouldn't tell my client. And a lot of times we would write the progress notes at the end of the session together. That way they would know what was going in there. But they need to know that they have the right to review their file, what parts of their file they have the right to review, and what their responsibilities are with regard to treatment, such as showing up, paying their bill, staying clean and sober, not bringing guns or assaulting anyone. Generally, client responsibilities are pretty obvious, but they need to be stated ahead of time. Part of service coordination is going to be consultation. When you do consult, summarize the client's personal and cultural background, treatment plan, recovery progress, and problems inhibiting progress for purposes of ensuring quality care. Basically, you're doing a brown bag. You're doing a case presentation when you're seeking consultation. And that's fine. Most multidisciplinary teams will have a chance whenever they meet for people to present their cases, what's going on, and receive feedback from the treatment team. In order to be efficient, you need to understand terminology, procedures, and roles of other disciplines. So if you aren't familiar with any of the medications used in treating schizophrenia, for example, and you've got a schizophrenic client, you're going to need to review that before seeking consultation. Otherwise, you're going to sit there and go, huh? You think they should increase what? Why? That doesn't add a lot of credibility. Make sure you are aware of the terminology, like ambulatory detox, or methadone maintenance, or buprenorphine. Contribute as part of a multidisciplinary team. Just because you're not an MD doesn't mean you don't have something very worthwhile to say. Much to the contrary, you are the person who most likely sees this person most often and has the closest relationship. You have a lot to contribute about the client and about your experiences with similar clients and the environment, etc. Treatment is going to be much more effective if you actively participate. But you still need to demonstrate respect and non-judgmental attitudes towards clients in all contacts with community professionals and agencies, and also towards community professionals and agencies. You don't want to be dissing clients or other professionals. It's just not going to work. So be aware of not only your verbal attitudes, but also your nonverbals. If you have a chip on your shoulder, it's going to come out. If you have a beef with the physician that's on your multidisciplinary team, it's going to be obvious. So make sure that you process your stuff with your supervisor or with a colleague so you can effectively work with people who are on the team, because most of us don't get to choose everybody on our team. Substance abuse treatment can be characterized as a continuum arrayed along a particular measure. One such measure is the stage of treatment, case finding and pretreatment, treatment, and aftercare. During case finding and pretreatment, this is the screening process. This is where we identify people who are at risk. Primary treatment, pretty obvious. And then aftercare is that maintenance phase. Case management focuses on assisting the substance abuser in acquiring needed resources. Treatment focuses on activities that help the substance abuser recognize the extent of their substance abuse problem, acquire the motivation and tools to stay sober, and to use those tools. The implementation of the case management function is shaped by many factors, including the client's place in the continuum, their level of motivation to change, the agency's mission, staff's training, configuration of the team, the needs of the target population, and the availability of resources. We don't live in a perfect world. You're not always going to have a motivated client with a willing agency, super highly trained staff, and all of the resources you need. That's the exception, not the rule. So you need to be flexible, you need to be resourceful, and work with what you do have. Most often we find that we've got a lot more resources available to us than we regularly use. During case finding and pretreatment, you want to increase engagement by reducing barriers that impede the admission to treatment. Client reluctance to enter treatment into services can be reduced by motivational interviewing approaches, basic non-threatening education about addiction and recovery, reminding clients of past and future consequences of continued substance abuse, assistance in meeting the client's basic survival needs, and commitment to developing the case manager-client relationship. Now think to yourself about certain barriers or obstacles that some of your clients have had to coming into treatment. The one that comes up in my head over and over again is kids. They don't want their kids in foster care. They don't want their kids to stay with family, or they don't have family their kids can stay with, so what do? The other one that repeatedly comes up is job. They don't want to lose their job, yet they've exhausted all of their leave time, and a lot of times they haven't been at a job long enough to qualify for family medical leave. But once you help them overcome the obstacles and become ready for treatment, then you want to help them engage in treatment by first orienting them to the program. If you take away the mystique, the concern about what's going to happen, how's this going to go, walk them through the program. Let them know what's going to happen. They will be much more at ease and much more able to focus. In addition to providing orientation, you can orient treatment programs to the clients. It's important not to just dump somebody off with their bag and say, well, have a good life, I'll see you in 60 days when you're discharged. It's important to let the primary therapist know who this person is and what their needs are, because chances are the case file that has the assessment is not going to get there until after the client has already been entered in treatment, unless you have a very unique agency that runs like clockwork. So give the primary therapist a brief introduction, especially if you can do a face-to-face introduction, you know. Tom, this is Jim Bob. Jim Bob, this is Tom. He'll be your primary therapist. This is where his office is. And either let Jim Bob tell Tom a little bit about himself, or you can do it. That way, Tom knows what to expect. It's not until discharge that the day-to-day realities of living assume the most urgency. Clients in aftercare have an array of needs. They have been in a protected environment for 30, 60, 90 days, maybe more. Then they get out there, and they've got credit agencies calling them, they've got to find housing, they've got to pay rent, they've got to do a whole host of things they haven't had to do. They've got a lot of responsibility just thrust on them all at once, and it's overwhelming for most clients. So it's really important during the aftercare phase, especially for the first 3 to 6 months, to maintain a close connection with your client and support them through doing the next right thing, because they learned in treatment what to do. Now they just have to do it. The primary difference between treatment and case management is case management's focus on the client's need for community resources. The findings from the assessment, including skill deficits, support needs, level of functioning, and risk status, define the scope and focus of the service plan. The case manager isn't going to be anything and everything to the client. The case manager links the client with community resources. It helps the client establish their safety net so they know where to call when they need help. It's case management's role to explore clients' needs, wants, skills, strengths, and deficits, and relate those attributes to a service plan designed to address those needs efficiently. Focus on strengths. Most of the time, you can focus on strengths and the deficits will disappear. Help the client identify what they want, where they want to be, and what they need to get there, and they're going to be much more motivated to remain treatment compliant. While the focus of case management is to assist clients in obtaining social services, the goal is for clients to learn how to obtain those services. The client should be assessed for their ability to obtain and follow through on medical services, apply for benefits, obtain and maintain safe housing, use social service agencies, and access mental health and substance abuse services as needed. In order to reach the ultimate goal of independence, clients must also have vocational skills and should be assessed for reading and writing, skills in following instructions, learning disabilities, transportation skills, how they deal with supervisors and react to figures of authority, timeliness and punctuality, and telephone skills. The case manager can do this, or this can be done by the vocational rehabilitation counselor. It depends on your agency and the situation. When assessing client outcomes, it's important to use a deliberate, carefully considered approach to identify goals which offer benefits that go beyond the actual acquisition of needed resources. So what does that mean? That means Sally Sue getting food stamps is the basic acquisition of needed resources, but we want them to take it a step further. Our goal should be for Sally Sue, to learn how to identify her need, find the agency that can meet her need, link with that agency, and obtain the needed resource. We need to teach her how to fish, not just give her a fish. Clients need to learn a process for systematically setting goals. When we develop the treatment plan or the service plan, oftentimes we're the ones who write out the goals. It's helpful even if in the very beginning you work with the client and say, okay, this is where you want to be. Now let's talk about 5 things that you need to do to get there. What are your 5 steps that you need to take? Help clients learn how to set sub-goals to reach ultimate goals. Help them gain mastery of themselves and their environment through brainstorming ways around barriers to a particular goal or objective. Tell them to take "I can't" out of their vocabulary. If they want to do something bad enough, they can. It's just a matter of being resourceful. What needs to happen? And clients benefit by experiencing the process of accessing and accepting assistance from others in the process of goal setting and goal attainment. One thing that's often helpful is to work with case management clients in a group when they're all working on goal setting and goal attainment, because they can pair up or they can get in small groups and they can brainstorm ways to solve problems. Even if they're only solving mock problems, they're sharing ideas, they're developing the skills for setting incremental goals. You can also give them common problems like getting to work or finding a job. Have them break into small groups and identify the steps they need to take in order to achieve that goal, and then share. During primary treatment, the case manager must continue to motivate the client to remain engaged and to progress. You need to organize the timing and application of services to facilitate client success. It's not going to do any good to initiate intensive therapy and wait 6 months to have them see a psychiatrist if they need to have medication for a psychiatric disorder. Likewise, medication alone probably isn't going to do it, so it's going to be important to make sure that you coordinate these things so they work in harmony and in unison with one another. And it's important to provide support during transitions, to intervene to avoid or respond to crises, to promote independence, and help the client develop external support structures to facilitate sustained community integration. Don't make them dependent on you. Make sure that they have other resources out there, other agencies, other people, other contacts that they can use in order to maintain their independence in the community. 5 tasks relate to linking that should be undertaken with the client before actual contact with a needed resource even occurs. You want to enhance the client's commitment to contacting the resource. You don't want to make a referral and have the client no-show. It doesn't look good for them, doesn't look good for you. Plan the implementation of the contact. Talk with the client about what needs to happen and when it needs to happen. In early recovery, sometimes it's best to have the client do the referral for themselves, but they do it in your office. Analyze potential obstacles to that person attending the referral session. Transportation, child gets sick, whatever. Brainstorm resolutions to those problems. Okay, your car breaks down. How are you going to get there? Your kid gets sick. What are you going to do? You can't just call up 30 minutes ahead of time and say, I'm not going to be there today. Model and rehearse the implementation of this referral. What's going to happen when you show up at this person's office? And summarize the first 4 steps for the client. You've told me that you really want this referral for these reasons. This is what you're going to do, when you're going to be there, what you're going to bring. If any of these situations arise, you have a backup plan. And this is how it's going to go on the day of the referral. It's unfortunate, but there are still times when you're going to have to advocate for your client. And this can be for a lot of different reasons. Sometimes clients are refused resources due to discrimination. They're refused services despite meeting eligibility requirements. They're discharged from services for reasons outside the rules or guidelines of that service. They refuse services because they were previously accessed but not utilized. Or you have a belief that the service can be broadened to include a client's needs without compromising the basic nature of the service. I'll give you some case examples. We had a client who had previously been enrolled in services multiple times and had made some pretty poor choices. He has an Access 2 diagnosis and tended to be inappropriate with female clients and female staff members. There came a time when he wanted access to services again, despite the fact that he was discharged against medical advice 3 prior times. His counselor, in this case, we didn't have a case manager assigned, advocated for him to re-access services, but he was put on a strict written behavioral contract. Sometimes clients are refused resources despite meeting eligibility requirements. There are occasions when clients meet eligibility requirements, but they have either been through the treatment system before, or there's no room at the inn. And a particular case comes to mind where my facility was full. Absolutely, positively, busting at the seams, no beds available, full. And the case manager for this particular client advocated with my supervisors, and that client was admitted, and they brought in a bed and put it right in the middle of the day treatment room for that client to sleep on. Now, thinking about environment and privacy and all those other things, you can see where there's a problem here. But that case manager did advocate for that client, and that client was admitted to services. She met the requirements, and where there's a will, there's a way. She was admitted despite us being over capacity. There are also times when clients have been wanting, for example, to be in residential treatment, but they've left against medical advice multiple times. They come in, they do 2 weeks, they get fed up, they leave. Sometimes those clients are required to complete a week, a month, 3 months in intensive outpatient to demonstrate their commitment to treatment before they're admitted to residential. Now, if they don't stay clean and sober the whole time, we don't expect them to. But if they're trying, they're coming and they're participating, then generally the client would be admitted at the next available bed. Linkages may be largely useless because some organizations misrepresent the number or types of services they actually offer or have available. Make sure that if you refer somebody to an agency that says they're going to do something within this time frame, that they actually do it within that time frame. This whole notion of, yeah, we have this service, but oh, you're going to be on a waiting list for 6 months, that doesn't help the client. Make sure that the services you're referring somebody to still exist. A lot of times they are short-term grant-funded things that have 1 or 3 years of funding and then they disappear. So don't refer them out into nothingness. Some organizations are incompetent or too poorly managed or staffed to provide adequate services. And adequate means timely, effective, and competent. So even if your client's getting seen in a timely manner, and theoretically they're saying a service is being provided, if you're not seeing what you would expect the benefits to this service to be, talk with your client about how effective this relationship is. If it's a waste of their time, then terminate the service. And some agencies are too far away for clients to use. Referring somebody to, I'm in Gainesville, referring somebody to Orlando or Miami to see a specialist once, you might make an argument for it. Once a month, it's not going to happen. That's just not practical for a client to drive 2 or 5 hours to see a specialist once a month. There are several factors that influence the provider's ability to conduct case management. The first one is social services agency's number, type, responsiveness to clients with substance abuse problems, openness to case management, and relationships with each other. You can't do case management if the people in the community, if your referral resources are unwilling. If you've got a situation where vocational rehab won't work with your people until they've got a year clean, or you've got a physician who won't prescribe any psychotropic meds until somebody has 3 months clean, then you're going to have a hard time doing adequately timed case management working with those resources. Community leaders' support for or neglect of substance abuse treatment and their response to case management concepts. For the system to work in a community-based model, the community leaders have to be behind it. The economic situation in the community. The more economically stable a community, the more the resources. So in rural Nebraska, you're going to have less services than you are in the middle of downtown Orlando. You're going to have more nonprofits, more people who can volunteer, more people with special expertise in economically stable and theoretically more urban communities. Other factors influencing the provider's ability to conduct case management include funding for a program startup and program continuation. Like I said before, a lot of times funding is from grants, which end after a year, 2 or 3 years. Other things include incentives for entering into an interagency agreement. Stakeholders who recognize the benefits to their agencies will help facilitate case management. When agencies create formal agreements, there has to be a win-win on both parts. So it's important to sell the benefit, not just the workload, to the agency with which you want to link. Predictors of success: gainful employment, family and social support, and lack of a coexisting mental illness. Now, the coexisting mental illness isn't as much of a factor if it's adequately controlled. But if you have someone who has an unaddressed mental illness, they're not going to fare nearly as well. Vocational services need to be an integral part of all substance abuse treatment programs. They must focus on pathways into careers, on job satisfaction, and overcoming a variety of barriers to employment, as well as on the needed skills for maintaining employment. Many of our clients have had difficulty getting or keeping a job for years leading up to treatment. Therefore, it's going to be important for them not only to learn how to interview for a job and what is expected of them on a job, but also how to get a job that is going to be a career, something that they will advance in, somewhere that they will stay for a while. Their first job may be just that, a job, somewhere to prove themselves. But they need to have hope that they'll be able to transition into something that's a career in the near future. A number of changes affecting today's workforce must be taken into account when delivering vocational services to substance abuse treatment clients. There's a lot of pressure, especially in today's economy, for people to get and maintain jobs. The unemployment rate is extremely high, so employers can be choosy, which makes it harder for our clients to get and maintain jobs if they have a poor work history. The other issue is the high amount of liability associated with employing substance abuse clients and the impact that that may have on workers' comp insurance. They can't discriminate against someone for having a substance abuse problem. It's a DSM diagnosis. It is a very legitimate disability. But they do. Let's face it, it happens. Someone with the same qualifications who doesn't have a substance abuse problem will probably be chosen over the person with the problem. There are 3 key elements essential to effectively addressing the vocational needs of clients. Use screening and assessment tools specifically for vocational needs. Develop and integrate a vocational component in the treatment plan. And counsel clients to address their vocational goals and employment needs. Again, case manager may do this, or the vocational rehabilitation counselor may do this. But you need to speak the same lingo, and you need to be aware of what the assessments are saying and where the client wants to go with their career. There are several laws in the area of welfare reform with which alcohol and drug counselors need to be familiar. These laws must be monitored closely because they will signal time periods when financial support will be terminated for clients. There are a lot of laws that impact especially financial benefits that clients can receive. Certain Section 8, we call it in Florida, low-cost government-subsidized housing is unavailable to clients with drug convictions on their record. Certain benefits are not available. Victims' compensation is not available under certain circumstances when the victim has a history of drug charges. There are many levels of treatment services: inpatient or outpatient detox, inpatient rehabilitation, residential rehabilitation, and outpatient services. Inpatient, outpatient detox. If a person needs monitored detoxification, you're going to want to choose between these two. If there's a co-occurring mental disorder or if the person is at high risk of medical complications, you're not going to want them in ambulatory or outpatient detox. They're going to need to be inpatient. A lack of social supports at home, a lack of a home, or the use of multiple substances are also other reasons indicating a need for inpatient detoxification. Patients who are brittle, frail, suicidal, or medically unstable should receive 24-hour primary medical, psychiatric, and nursing inpatient care in medically managed and monitored intensive treatment settings. This is the definition of inpatient rehabilitation. In contrast, residential rehabilitation programs provide a slower-paced, more repetitive treatment approach for older patients, and services range from high to low intensity and can be delivered in specialized care settings. So this is not so much the hospital setting, but more of a long-term residential setting. Outpatient services vary greatly in the intensity of treatment. Everything from day-long, 5 to 7 days a week, to 3 hours, 3 days a week, to once a week, and may include any combination of individual or group sessions. The consensus panel recommends that treatment programs adhere to the following principles. Older adults need to be treated in age-specific settings when possible. Culturally, older adults tend to be different than younger adults. They have different psychodynamic needs. They have different feelings about what should be expressed and what shouldn't. And they're just going to tend to be more comfortable among their own peers. You need to create a culture of respect for older clients and take a broad, holistic approach to treatment that emphasizes age-specific psychological, social, and health problems, including dementia, Alzheimer's, brittle bones, risk of falls, disorientation, heart problems, things that typically come up. Keep the treatment program flexible and adapt treatment as needed in response to the client's gender. Just because someone is elderly doesn't mean that they are only elderly. They are members of multiple cultural groups. They have multiple self-definitions that we need to be sensitive of. Many actions and speaking manners demonstrate respect in ways the older client will understand, such as abide by the manners that older clients see as customary, such as not swearing, being polite, don't go in dressed in a halter top. Ask the individual how he or she would like to be addressed and introduced to others. Use surnames and formal terms of address until given permission to be more familiar. Nothing is more unnerving to me, and it's my little pet peeve, of somebody who walks in and meets someone who is older for the first time, and they're just like, "Hey, John, how you doing?" At the very least, it should be Mr. John, but generally it should be Mr. whatever his surname is, to show respect. And then if that person wants to be called something else, they have the power to say, yes, you can be more familiar, or no. Avoid condescending or patronizing behavior. Don't treat them like they're frail and breakable or confused or anything that you would find just particularly distasteful if you were in their position. Speak directly to the client, not the client's spouse or adult child, when the client is present. Even if they are not able to respond, say they have advanced Parkinson's or something that makes communication difficult, it's still more appropriate to talk to the client, make eye contact with the client, than it is to talk about them with their significant others who are in the room. How demeaning would that feel? And recognize the client's privacy and personal space. If you're doing home visits, don't go looking around at, all this stuff in all the rooms and what have you. That's just impolite. Recognize that they have privacy. If you have had discussions with them before and you show up to have a session with them and somebody's in the room, don't just launch into discussing personal information. Recognize them as feeling human beings, even if they aren't able to communicate in the same way anymore. Demonstrating respect in ways the older client will understand also includes talking to the client, honoring their pain, needs, and joys. Don't tell them the pain's not as bad as they feel. Don't diminish the emotional pain of the loss of their husband or their friends. Be willing to listen to their joys and things that they need and things that they like. Let them tell you stories about what life was like back in 1920 or whatever. Fulfill the client's request to speak to his or her clinician immediately if possible. A lot of times, older people don't advocate for themselves and don't tend to speak up, so they tend to fall through the cracks. So sometimes they need case managers to advocate for them in order to get the attention that they need. In a treatment program, a number of shorter, informal sessions may be more valuable than a longer scheduled session. 15, 20 minutes. Go on a walk. Do something more informal than just sitting in a room staring at each other doing traditional counseling. Most older people don't feel comfortable airing their dirty laundry. So if you're sitting in that face-to-face situation where there's really kind of nowhere for them to feel protected, it's harder for them than if maybe you're sitting on a picnic bench feeding the birds or walking around the treatment facility. Maybe there's a park nearby or something. Respect the client's spiritual concerns and desires to discuss meaning and purpose in life. And this is where that multicultural and value assessment comes in really strong. Clients may ask what your perception is of the meaning and purpose of life. Clients may tell you what their perception is, but you need to be open to what their perception is and be willing to help them seek out information if they don't know and they want to come to some conclusion to deal with this existential angst. Case managers must have strong linkages through both formal and informal arrangements with community agencies and services, such as medical, home health agencies, specialized housing, and public and private social services providing in-home support for housekeeping, meals, etc. Now, this is more important for your elderly population than for your younger substance-abusing population. But there are times even when younger people need assisted living facilities. Be aware of what's out there and in your community to meet their needs at the lowest level of intensity possible for what they need. You don't want to put them in a hospital situation if they simply need someone to check in on them every few days or so. Formal and informal arrangements can be with faith communities, transportation services, senior citizen centers, senior employment programs, community organizations that place clients in volunteer work, legal and financial services, and the Area Agency on Aging. Legal and financial services. You don't like to talk about it a lot, but older people do have the concerns of their wills. When they pass on, they want to make sure that everything is legally binding and there's not going to be a lot of problems, and they want to know that everything's taken care of. They need to have a place where they can socialize with people of their same age. Many communities have specialized community centers for seniors. Find out what your community has. Now, people may be compliant in a lot of different ways, but one of the most common things you see for noncompliance is medication. Causes of medication noncompliance include a lack of judgment or misconceptions about the drugs. If I take this, I'm going to become an addict. No, probably not, especially when it comes to like SSRIs, your antidepressants. Or I only have to take this when I need to. Again, your antidepressants, your SSRIs, take several weeks to take effect. You can't just pop a Zoloft like an aspirin when you have a headache. An inability to manage the medication regimen because it's complex or the patient has persistent memory problems. We've all seen our grandparents or aged aunts or uncles or whatever have these pill boxes that have like 14 pills in them, and they have different times of day, and like 4 times a day they're taking handfuls of pills. I couldn't keep it straight. It's important to work with the client and the physician to identify what medications are necessary, maybe even write it down, color code the bottles, help the patient make it as manageable as possible. Make sure they have the resources for purchasing and storing medications, and that they're not intentionally misusing medications or trying to get medications for reasons other than what they're really telling the doctor. Other things that need to be considered is when our patients, elderly or not, are continuing to use alcohol or other contraindicated drugs while taking prescribed medications, or if they're engaging in contraindicated activities while taking medications, such as driving motor vehicles, spending time in the sun, or doing anything else that might make it dangerous for them. Failing to tell the prescribing physician about all other medications being used, or reporting significant or unexpected side effects, and storing medications improperly, such as not refrigerating medications that require cold temperatures. The other issue you see with medication noncompliance is patients who experience side effects that they're not warned about. And this is another place where it's important to advocate for your client to help them understand where they can find information about what side effects to expect. And if you know those side effects, then tell them. They may experience any or all of these, and when it'll go away, and what other clients who you've had that have been on the same medication have reported to you. This will help a lot with encouraging them to stay on the medication. It's also important to be aware of medications that clients are not supposed to be taking. Elderly patients have a longer period of time. It takes a longer period of time for medications to clear their liver. So especially things like benzodiazepines, Valium, Xanax, and some of your anti-epileptic medications like Klonopin, which is also tends to be used as a benzo, take longer to clear the elderly person's system and therefore can build up toxicity. So if they're taking it more than they should, or if they're experiencing extreme reactions to the medication, it's important that they talk it over with their physician. The following professionals should ideally be available to a treatment program: a geriatrician, which is a geriatric physician, a geriatric psychiatrist, a geropsychologist, a counselor who specializes in treating elderly people, a nutritionist, and an activities director or recreational therapist. As you can see by all the special names, elderly people have special needs, and there are whole programs designed to teach people what those needs are. So if you can identify people in your community who are trained in working with the elderly population, even if you can't refer to them, you can consult with them, and that will make your life a whole lot easier. Other people you might consider having on the treatment team are a chaplain or other members of the clergy, occupational therapists, social workers, and peer counselors. Peer counselors are often particularly valuable because they have life experiences in common with the clients, and being of that same general age group, clients are often more willing to open up to their peers than they are to some young whippersnapper who comes in and thinks that he or she knows everything. Elderly people are only one special population. There are bunches. But the other one we're going to cover in this particular course is case management with offenders. When you're working with offenders, obviously they're either getting ready to be discharged or have been discharged. There are certain things that they're going to need. Vocational training, job readiness assessment and preparation. You're going to need to help liaise with employers and prepare them, the clients, for their interview and how to answer all those questions about, do you have a felony conviction, have you been in jail, etc. Conduct a literacy assessment and make referral for any further education or learning disability testing. Anger management training. Conduct a criminal thinking assessment and refer to treatment as necessary. And criminal thinking and addicted thinking are very similar, so many addiction treatment programs can handle working with people with criminal thinking issues. HIV education, testing, and counseling is very important. And assistance in accessing state or federal entitlements such as Medicaid, TANF, Temporary Assistance for Needy Families, WIC, Women, Infants, and Children program. This provides supplemental income to help ensure that children get the sustenance that they need. Food stamps and housing programs available for clients willing to enter treatment. In summary, case managers provide continuity in a medical community that's becoming over-specialized. Case management views the person as a whole and recognizes the need for biopsychosocial interventions. It's often not a billable service, but it's one in which interns and volunteers can assist. It's important to empower the client to do as much as he or she is able to prevent from fostering dependency. And case management greatly increases clients' chances of remaining sober in early recovery.